Now in the corneal disorders, we will discuss dystrophies. Dystrophies are like degenerations. These are also opacifying, causing disorders of the cornea, but they are genetical, slowly progressive, and can reach to a stationary stage or progressive stage. Okay, so these are like degenerative conditions, but they are genetical and can reach to a stationary or progressive stage. Okay, we have many different types of dystrophies. The dystrophies involving the epithelium of cornea and Bowman's layer, they are called anterior dystrophies. The dystrophies involving the stroma, they are called stromal dystrophies. And the dystrophies involving the endothelium, they are called posterior dystrophies. Okay, so we will discuss these dystrophies and their subtypes now. Okay, the first one is anterior dystrophy. Anterior dystrophies, they all are autosomal dominant and they require lamellar keratoplasty for their treatment. The first one is microcystic dystrophy. Microcystic dystrophy is the most common of all dystrophies of the cornea. Okay, what is happening in microcystic dystrophy? The adhesion molecules between the epithelium and the Bowman's layer, there are adhesion molecules. So there is the genetic problem in these adhesive molecules. Okay, so there is problem in these adhesive molecules between the Bowman's layer and the overlying epithelium. So what will happen? There will be ultimately the areas will degenerate and this destruction will ultimately leads to opacity. And this opacity will clinically appear dot-like. Okay, we will have dot-like opacities or fingerprints like opacities. Okay, so we will have dot-like or fingerprints like opacities will be present, will be seen clinically in microcystic dystrophy. The most common form, there is the problem in the adhesive molecules. It will clinically presenting as a dot-like or fingerprints opacities, and it is presenting mainly in the later life. Okay, this is microcystic dystrophy. The second one is the Rees of anterior dystrophy is the Rees-Buckler dystrophy. In the Rees-Buckler dystrophy, there is the problem with the Bowman's layer itself. Okay, so there is the genetic problem with this Bowman's layer itself, which disintegrate. Okay, which disintegrate due to some genetic problems. What will happen then? There will be disintegration and destruction, which will lead to opacities. In Rees-Buckler dystrophy, the opacities, clinically the opacities will look like ring. Okay, so we will have ring opacities. In Rees-Buckler, we will have ring opacities, and it is presenting in early childhood. Okay, there will be the recurrent attacks of pain, photophobia, lacrimation, etc. Okay, so this is the Rees-Buckler dystrophy. Now the third one of anterior dystrophy, it is the Meesmann dystrophy. In the Meesmann dystrophy, there is the problem with the epithelials, with the cytoskeleton of epithelial cells. For example, if I take one epithelial cell, we know that there is cytoskeleton in the cells, and then the cells will ultimately be destroyed. And there in the Meesmann dystrophy, there is the formation of, due to this fluffiness of the cells, these will destroy, and there will be the formation of small cystic spaces. Okay, in the epithelium, there will be the formation of small cystic spaces. Remember, Meesmann dystrophy, it is a rare dystrophy, and even if it is present, it is mostly subclinical. Okay, the last one of the anterior dystrophy, we have the recurrent epithelial erosion syndrome. Now there is problem with the adhesive molecule of epithelial cells. We know that if this is the epithelial cells, with the underlying Bowman's layer, it is attaching through adhesive molecules, which are called hemidesmosomes and other molecules. Okay, so now there is the genetic problem in these hemidesmosomes. Okay, or attachment molecules, and it is also a rare condition. This is called recurrent epithelial erosion syndrome. So these were some of the subtypes of the anterior dystrophies. Now the dystrophies involving the stromal area, these are called stromal dystrophies. The stromal dystrophies, like the anterior dystrophies, they are also autosomal dominant and require lamellar keratoplasty. But remember, except the macular dystrophy, okay, the macular dystrophy is not autosomal dominant. So the first one is the granular dystrophy. In the granular dystrophy, the pathology is that there is the excessive deposition of hyaline material in the stroma. There will be the excessive hyaline deposition, okay, in the stroma. And this will be presented clinically as a milky opacities. The opacities will look like, there will be dense granular opacities which will grayish or white. So it will give us a milky appearance. So there will be a lot of granular opacities, okay, due to the deposition of the hyaline material. These opacities are regularly spaced and they look like milk, okay, so that's why we will have milky regular spaced opacities and granular dystrophy. And it is presenting, the vision is good until 40 years of age, okay. The second one is the lattice dystrophy. In lattice dystrophy, there is the deposition in the stroma, there is the deposition of misfolded protein called amyloid. So there will be the excessive deposition of amyloid in the stroma. And clinically, the opacities will look like crisscross lines, which will look like that there are cracks in the window, okay. So in lattice dystrophy, the opacities will be crisscross, okay. So there will be crisscross opacities which will look like that there are cracks in the window, okay. This is the vision is deteriorating early in this type of dystrophy. The third of the stromal dystrophy is the macular dystrophy. So what is happening in the macular dystrophies, like the granular and lattice dystrophy, there is the deposition of another substance which is called which is a polysaccharide called glycosaminoglycans. So there will be the excessive deposition of glycosaminoglycans in the stroma, which will clinically will look like there will be the opacities. We will have dense opacities, okay? We will have dense opacities. In between these opacities, we will also have haze, okay? So in between these dense opacities, there will be haziness in between these dense opacities, okay? So this is due to the deposition of excessive polysaccharide called glycosaminoglycans in the macular dystrophy. Okay, so these were the stromal dystrophies. Now the last one is the posterior dystrophies, which involve the endothelium. We will discuss only one type which is very important, which is the Fuchs endothelial dystrophy. Fuchs endothelial dystrophy. What is happening? It is a bilateral condition in which, due to some genetic problems in the endothelial cells, the endothelial cells will disappear, okay. So they will degenerate, disintegrate, waste. The endothelial cell, due to some genetic problem, will disintegrate, will disappear. So its onset and presentation both are late, and remember, it is more common in females, okay. So it follows 4 stages, okay. Its pathology has 4 stages. The first one, there will be the formation of gotata. What are gotata? Gotata is when these endothelial cells, when they disappear, when they disintegrate, what will happen? There will be the collagen fiber will deposit over here, okay. And these collagen fiber will deposit in such a way that it will, on the slit lamp, it will look like a beaten metal, okay. So like when a metal is beaten, when we look through this endothelium through the slit lamp, there will be a metal beaten appearance, which is called gotata, okay, due to the disorganized deposition of the collagen fibers. Now, ultimately these gutata will be followed by the corneal edema. Okay, the fluid will rush into the cornea and it will causes the corneal edema. We know that endothelium act as a pump and it remove the extra fluid from the cornea. So now it is there is no pump, so the fluid will rush. And this corneal edema will be followed by bullous keratopathy. Means that there will be so much fluid in the cornea, in the stroma in the cornea, that there will be the formation of bullae. Okay, there will be the formation of bullae. This is called bullous keratopathy. Okay, this is called bullous keratopathy. And ultimately, this bullous keratopathy will be followed by scarring. So there will be scarring in the whole cornea will become opaque. Okay, so there will be scarring in the whole thickness of the cornea. And now the only final treatment for this type of condition is full transplantation of the cornea. We have to remove the entire cornea. Okay, so gutata formation will be followed by corneal edema, then bullous keratopathy, and the bullous keratopathy will be followed by complete scarring. So these were the dystrophies. I also have prepared notes. I will give you the link in the description. You can go through the notes and you can learn more. Thanks for watching the video.